was the issue of ICHF, where we had 3 regions which had not yet started the implementation. But to date, all the regions are implementing ICHF, and possibly after 1 year we will be in a level to evaluate the progress so far. But the other resolutions are still under implementation, and we will have the reporting after 6 months. And the committee have been formed to track the progress of all resolutions, which will be spearheaded by the President's office. The other issue which was strengthened to follow up implementation is the issue of leadership and accountability in implementation of the health interventions. And this is one of the examples to follow the Makole model, which and it was advised that every district, every council should implement. So this is also in the initial stages of implementation in our councils. But also the issue of the community engagement using the Utilo model. And this is the model which we are now starting to implement in our councils. So after some time we'll be in a level to report the actual progress. But in general, the big issue here is strengthening leadership and management. And this is an issue which we think if every council will be in a position to make a follow-up of interventions in the region, and planning together with all partners whom we are implementing in our local areas, it will be the only issue which can make a difference. Thank you.
Thank you.
Yes, my name is Dr. Juma Mfanga. I'm a city council, but also the chairperson for all DMOs. I would like to compliment for the issues which has been said by Dr. Chaota. We have already put in place the issues like issue of the CHF, issue of the prime vendor, and other issues which has been discussed in DMOs, RMOs meetings. Currently, we are trying to set out a scorecard, meanings to respond to issues which has been raised during the DMOs, RMOs meeting. We have already selected number of DMOs who will be taking a chance to develop a scorecard in the coming next month. But also, as the days goes on, we have a way of responding on the issues there. In the issue of Macaulay and the Utilo model, we have already selected some of the facilities as it has been presented by the chairman of the RMOs in the morning. That we have selected almost 3 facilities in each district in such a way that it will start as a model in each district. Goes on. Some of the healthcare workers will go and learn to selected facilities and try to find a way to cope with what has been done in entire district. This will automatically reflect what you want to do in the future days. On the issue of prime vendors, we have a couple of numbers of regions which has already started. Taking example in Mwanza region, of course we have, what I can say is we are doing good. We are doing good, and comparing to the previous system we were using before the introduction of a prime vendor system, we at least we have the commodities nowadays. If we miss commodities from the MOCD, we can get it from the prime vendor, and the turnaround time is short compared to the previous style we are using to buy anywhere. But nowadays you can know how to channel if you miss the commodity from the MSD, you can go to the prime vendor and automatically get the commodities. This one strengthen the area of health system deliveries. Last but not least, with the introduction of the construction of the and renovation of the infrastructures in health system, we are at least in place nowadays to deliver the health service deliveries in comfortable environment. We are proud and we hope with the effort we have in the government nowadays and the recruitment of the healthcare workers, we believe we are going in the right track. So thank you very much.
Thank you. Truda, are you happy? Are you happy? You have seen the action has started. Okay.
I think much has been said by my colleague. So maybe to add on issue of stunting, PURAJ in collaboration with the Minister of Health, we started to implement the performance contract. Tuko tunaongelea swala la kuhusiana na mikataba ya utendaji kazi kwenye issue inayohusiana na stunting. Wizara ya Afya kushirikiana na ofisi ya Rais TAMISEMI ilisainisha mikataba baina ya waziri pamoja na wakuu wa mikoa, na kila kota huwa tunafanya review kuangalia namna gani wameweza kufanikisha utekelezaji wa afua ya lishe. Kwa hiyo hilo limetusaidia kwa maana kwamba waganga wakuu wa mikoa na wao wameweza kucascade kwenda kwenye ngazi ya halmashauri na halmashauri kupeleka kwenye ngazi ya jamii. Hiyo ni eneo moja. Sasa kuna swali ambalo alikuwa ameuliza pia Dr. Bujari kuhusiana na swala la uwajibikaji. Akirifaa awamu iliyopita. Awamu hii pia tumeweza kufanya swala la uwajibikaji hususan kwenye eneo la mama na mtoto, ambapo Mheshimiwa Makamu wa Rais wa Jamhuri ya Muungano wa Tanzania mwaka jana pia alitoa maelekezo kwa wakuu wa mikoa nchi nzima, na kwamba hayo maelekezo yashuke pia kwa wakuu wa wilaya chini ya kampeni ya kusema tuwavushe salama. Kwa hiyo ndani ya hii kampeni kuna viashiria ambavyo vimewekwa ambavyo tunavyoweza kuvipima kila robo kupitia scorecard. Japokuwa kitu ambacho tunaweza kusema hii scorecard yetu tunaendelea kuiboresha ili kuongeza uwajibikaji zaidi. Kwa hiyo kwenye eneo hilo ni kwamba linaendelea. Moja ya kitu ambacho tulikuwa nadhani ni cha muhimu kuboresha ambacho kilikuwepo kwenye awamu iliyopita ni swala lile la kuweza kuviripoti vifo, especially kwa viongozi wa kisiasa ndani ya masaa 24. Kwa hiyo hili ni moja ya eneo ambalo pia linaangaliwa. Kubwa zaidi tutamuomba baadaye tena Mheshimiwa Mwenyekiti Dr. Makuani aweze kugusia eneo hilo, kwa sababu ni eneo ambalo tunaliona ni la msingi, na sisi sote hapa tungependa kwamba hamna mama anayepoteza uhai kwa kuleta uhai mwingine. Masuala mengine kama walivyokuwa wameongelea mwenyekiti, katibu wa waganga wakuu wa mikoa pamoja na mwenyekiti wa DMOs. Kwa hiyo tumeanza na hili kwa sababu mkutano tumeumaliza juzi tu, lakini nadhani baadaye tutaweza kutoa utekelezaji wa maazimio hadi tutakapokuwa tukienda. Asante sana Mheshimiwa Mwenyekiti.
Thank you very much, Dr. Ntuli. So in short, he has mentioned that government, they've started performance contracts, and they start from the level of minister to the regional commissioner, where there's an agreement on following up nutritional issues, for example. And now the RC will move them down to the councils, and the councils move down to the community. And this is also trying to involve all sectors in issues of nutrition and like. And on the issues of accountability, as it happened in the previous, also here, and this is a government of accountability, they've done the same, and she gave instruction to the RCs, who now have also agreements with the DCs and below with a project called Tuavushe Salama. Like if you are crossing a river, you help the ladies to cross safely so that they don't drown and die. And using the scorecard, the RMS scorecard, so it's which needs improvement, but it is being used, and at the moment deaths are required to be reported within 24 hours. So, and regarding the recommendation, he supported the RMOs and DMOs who they said, and that they have a framework of following up of those recommendations, which they'll be within PORAG. So I think we are done for that, and I would like now to move the next session. The next session is twofold. One, we'll have a presentation from JAP, who will tell us from the MTR, summarize again the recommendations that are going to HHSP 5. Anything to improve the implementation of HHSP 4, now we are moving to HHSP 5. So it will give us what the MTR team thinks we should consider, and the approach on how, and then we go for lunch and group discussions immediately after that, and he will also give us some instructions for the group discussions we'll be answering. The names of the groups are not voluntary. So when you are having lunch, you'll see the names will be posted there. So we'll all go to the groups where we've been assigned, and you have a facilitator in the group and a rapporteur, and there'll be a roll call here. So don't run away. Okay? So we that's what we are going to have, and then what you submitted for the priority recommendations for next, we are going to synthesize. There will be a discussion tomorrow. That was more on the policy recommendation. So nothing is left unturned. So, yep, you want to? Japo, as you are preparing, the CEOs of NGOs, during lunch, you are not allowed to eat lunch until you meet the executive director of TNCM. There's something important to tell you. It's better than lunch. So you meet with Rachel Makundi, meet before lunch. Yeah. Executive secretary, she says she's not executive director, which is the same. It depends on what you do. So the CEOs, you meet with him. Yep.
Thank you, Madam Chair. Thank you, moderator, for this opportunity to give you instructions for the work after lunch. Because, as you heard before, we are using this opportunity for the HSSP 4 midterm review results to feed into the HSSP 5 formulation. You may be aware that we are talking about midterm review, though we are already at the end of HSSP 4. So there is short time for preparing HSSP 5. And Dr. Catherine showed you the time frame and it is really very short, so we really need to use the opportunities that we have for getting your ideas and suggestions. And from the discussions that we hear this morning, there are many, many vibrant ideas that we should collect from you this afternoon to be an input for the formulation of HSSP 5. First, I'm going to give you a bit of the framework that we have developed in the committee, and you will hear a lot of things that were already mentioned by Max Mapunda and by others. Then we will talk a bit about how you should discuss, because it is important that we really look at strategies. Then I will mention briefly the recommendations that come out of the midterm review for HSSP 5, and then I'll give you in detail the assignment of the work that you're going to do this afternoon. So first, the framework. We looked at frameworks, and we picked this one, the Lancet Commission for Health in Africa in 2030, which is a think tank like these Wazee here in front of us, from all African countries who came together to strategies that we need to come to health. First of all, the people-centered health systems, I will elaborate on that has been developed by WHO, and that came out of the presentation of Dr. Mapunda. That is an important part, but it is also important to look at SDGs not only from the perspective what do we all need from other sectors to improve health, but also how can health contribute to improving all the other SDGs. So not only inward looking, but also outward looking, and make more a case that we as health people can contribute to development of the country, can contribute to improvement of all the other SDGs. So it is a two-way process. The second recommendation of this commission is to may have a comprehensive approach, looking at the systems across the board from what may be done in United States or in Europe, but let's look at how we can achieve with local values, sustainability, equity, and use the traditions, the positive traditions that we know in our country that should be used. And of course, the main focus of an HSSP 5, and which has been mentioned by Max as well, is inequities. If we want to bring the country forward, we really need to help the people who are most disadvantaged and need better health. And those are not only the ones in remote rural areas that we traditionally think of, they are also in the urban areas, like the target populations that were mentioned. So inequities are not only about rural-urban divide, but also the poverty within urban areas. Health is an investment, and it is a priority for government to achieve, and the minimum that has been set is $84 per capita, and we heard yesterday that it is still at 34 in Tanzania, but we should look at not only at government saying government should pay, we should look at how different resource mobilization can be developed. And we should make use of changes in society. Things we're mentioning, we see a tremendous urbanization, we see a much better educated population, we see Tanzania moving to middle income level status. So that means that we must piggyback on those changes and incorporate them in our strategy. How can we use the changes in society to look at development of an HSSP 5? And how can we look at domestic and internal resources and align them to this strategy? And we have been talking often about off-budget, off-plan type of collaboration, we really need to make headway to align everything to increase efficiency. And one of the conclusions of the MTR was that we have already gained so much efficiency, but there is still more to be gained by harmonization and alignment. One of the slogans for this meeting. We need to capitalize on innovations, not only the innovations in technology, but also the innovations in education, in new competency-based learning, in new governance systems. We see how direct health facility financing has made a difference already. So these kind of innovations we need to embrace and bring into our HSSP 5. And I found it also interesting in the regional collaboration. I'm working also in Kenya and in Uganda, and there are many things that countries can learn from each other, and there's of course the East African community that can be used. So let in this HSSP 5 formulation we also look at how other countries in the neighborhood are doing what they are doing, and maybe there are some important lessons to be learned. So I summarized a few in this: look at local solution for equity, look at changes in society, look at resource mobilization and alignment, look at innovations. And so these 4 slogans I have put in a small cadre to take in mind when we start our discussion. And then, of course, many issues that are mentioned in the HSP 4 midterm review, like leadership, stewardship, civil society engagement, accountability, security of commodities, development of health workforce, research that was not so much mentioned in this meeting, but as somebody from a university, I embrace, of course, this thought that we should look at research more than we are doing now, and innovation. So all these topics, this Lancet Commission for Health in Africa 2030 says you should put on the agenda when formulating strategies. So that is one area we looked at. The other one is the people-centered healthcare, and Dr. Mapunda already mentioned this framework that already exists for some time in WHO, and that many countries are using in strategic formulation. And I will mention the 5 elements because they are difficult to read from this picture, but these are interacting elements that we should bring together for formulating a strategy. So there are 5 elements that WHO mentioned and that were also mentioned by Dr. Mapunda, is empowerment of communities and individuals to make effective decisions about their own health. Because we know health starts at home, and if people are not able to behave in a way that supports their own health, then whatever we do as a health sector will not contribute to improve their health. So empowerment of people is a crucial factor. Governance was already mentioned with participatory approaches and decision-making and performance evaluation. The monitoring that was mentioned this morning, looking at performance, is essential for better strengthening the structures. Reorientation of healthcare. We have to move away from focusing on only curative care. We have to include prevention, we have to include promotion, especially if we talk about NCDs. We don't want to go the way that Western countries went, where they left NCDs develop and spend billions and billions of dollars on treatment of diabetes that could be prevented if you are intervening in an early stage. So health promotion is the way to avoid an increasing burden of NCDs. Coordination across sectors. It was mentioned in the Health and Old Policies introduction, and here that many health workers don't even have time for that. We should make sure that the Buana Afyas are empowered to work more in intersectoral ways and work to bring all the intersectoral work that we find at higher level down to the grassroots level. And of course, we need to have an enabling environment of systems that support, the building blocks that support. And so if you add the two, you come to these 8 elements that we want you to look at this afternoon. So improved governance, improved resource mobilization and alignment, coordination across sectors. These are more or less on the part of managing health services. On the other part, community empowerment, using changes in society and gender, and shift to prevention, which are more focusing on what is happening in community and society. And then the other elements of local solutions for improving equity and using innovations in technology and management, which are all contributing to improving health. And the addition that Dr. Mpunda made, target for rural, urban populations, target for young and old across the age cohorts, that of course, when you talk about improving health, should be taken into account. So this is the kind of framework that we give you for the discussion this afternoon. That is important. Now we ask you to work on strategies, on planning of HSSP5. And just for reminding you, an HSSP5 is in the chain of planning and management. So of course there's a national health policy, and we know that the new policy is under formulation, and hopefully the new policy can already have an input while formulating HSSP5, but there are other policies of government that are important to look at. So HSSP5 is then the 5-year strategy for the health sector that should be guiding all the other planning mechanisms. What you use here in the SWOP is the annual strategic priority. They are here called now policy priorities, where you in fact take out of HSSP5 the important elements that could be achieved in 1 year, or that are important at least to start or to take further in 1 year. And then of course it was very much emphasized by Professor Monishi yesterday. There are operational plans that should be aligned with the HSSP5. We already heard that the Council, Comprehensive Council Health Plans already have for HSSP4 this kind of annex that explains how they should be aligned with HSSP5. But we also need at regional level, and we also need at national health quarters operational plans that take all these activities further. And if we talk about modernizing SWOP, we could look at how at regional level more operational planning is done based on the bottom-up approach and using the annual strategic priorities as an input. So this hierarchy of planning we have to look at, and we are asking you to look at the strategic level. And so here, this is the policy commitment matrix that presently is used, and this is not a strategy. If you follow a course, operational management at the business school, this is the kind of matrix you get there. What are your activities? What is the budget? Who is responsible? What are the indicators? What are the time frames? And if you look at many of those agreed policy commitments, they are in fact doing the work that councils are doing, because they are going even down. This should happen at ward level, this should happen in the facility level. let's please not go into that kind of planning, because this government is very smart. They have P.O. Rausch as the expert center for operational planning at council level. So we don't need, as SWOP, to go into operational level planning for the councils. We need to really focus at the strategic level. What is strategy? Looking at the guiding principles. What are our values? What are the important issues that we want to solve, like equity, like gender issues, like solidarity. Those guiding principles are important if you talk about strategies. And the long-term perspective. We are not solving the problem of getting the Land Cruiser repaired in facility X or what. We are looking at longer-term developments of what should we need to have a good transport system in place. So look with a helicopter view and don't be tempted to go into what is at the operational level. And it should be prioritized, it should be focused. The policy implementation metrics had 12 pages of dense activities. Many of them that cannot be realized in 1 year. And many of them were developed by specialists who did not look across the corridor to see how much is feasible. If you plan to have 30 CMOC centers working, including anesthetists and lab personnel for a blood bank, and you know that there is no staff available, and that you know you cannot have a blood bank in every health facility. So this kind of planning is dreaming. And if we talk about planning, we talk about the building blocks. And when I was here 35 years ago, I was in charge of building a new hospital, and there I learned that building blocks, you need cement to bring them together. All the building blocks on a big heap is not a building. So we need to link the building blocks and the systems when we talk about strategies. And that's why this afternoon we are not going to put you in the technical working groups. We are going to divide you across the technical working groups, because we want that interaction between different experts to take place. If you read the RMNCH report by Professor Menongi and Dr. Nyamtema, they say RMNCH is not for obstetricians or pediatricians. RMNCH is the comprehensive health service. That is their conclusion, and that is how we should think if we talk about RMNCH. The comprehensive health services need to be in place. So we want you this afternoon to think in a comprehensive way and not in detail, specific areas, leaving out what are the other necessary elements that need to be put in place. So if you talk this afternoon, we want you to formulate ideas for HSSP 5 and extract annual strategic priorities for the first year, but we don't want a series of operational plans that come out and cannot be implemented. So I'm going shortly over the different recommendations that come out of HSSP 4 midterm review that we want you to take in discussion. And we are going to divide you in groups, so not all groups are going to discuss all these recommendations, but as I say, because we want this interlinkage between the different building blocks, I mentioned them briefly. So the first recommendation for HSSP 5 is on governance, take D by D further. We have started working with the health facilities, we must empower them more, and we must create more community ownership of health activities in the community and in the health facility. We need to focus on flexibility. It was already mentioned by Dr. Mpunda that emergencies and new opportunities, new threats are coming, and if we are very rigid in our approach and say, oh, sorry, that's not our problem because it is not in our plan, we must have more flexibility to approach in a flexible way the opportunities and challenges that come to us. The national level is facilitating. And that is, of course, already the policy of government with the devolution, but we should really make sure that we are facilitating. So if we are talking about policy priorities in a swap, we should not interfere with the operational level, but we should facilitate. And collaboration was already mentioned before, that is again a strong recommendation. For healthcare financing, what we recommend is think of innovative new ways of mobilizing resources. It's too easy to say to government, bring more money, bring more money. Of course, it's very good that government needs to bring more money, but we also need to look at insurance schemes, to speed up insurance schemes, trust funds, social investment plans. Have we heard the private sector that they are ready to invest? If there are already last year 200 private practices, why don't we get private practices more aligned with our HSSP work and with our priorities? Why don't we really try to get them out of the purely curative work and also do more prevention? So we need to think in innovative ways of getting new partnerships and new ways of bringing money to the health sector. So the basic package of health service, of course, is important to continue with that work that has already been started and finalized. Human resources, you heard that is the key issue that we found in this midterm review, but you have to look at the human resources across the board. It's not just saying we have an establishment, let's fill these positions. That is not a solution. We saw, first of all, there's a lot of increase of productivity in health workers. And just thinking in establishment is not a solution, as we saw from all the regional analysis. We must look at the regional capacities, we must look at the regional problems for human resource planning. And so we must think of new ways using the existing information for planning and do it in a strategic way. Planning is not administration, planning is strategy. We also saw that there are many health workers that are very much motivated. We did hear about the work that DMOs and RMOs are doing together with their teams, together with all the health facilities. And of course, 90% of the people is doing their level best to provide services. And if we complain as midterm review that they don't do enough on tackling social determinants of health, it's partly because they don't know how to do it, but also because they are overburdened. So we need to facilitate that they can work better, and that motivation, satisfaction, compassionate care are the buzzwords that we should use to get the best out of people and to make sure that they continue the good work that they are doing. And we need in human resource development to look at the future. We are training people with curricula of the past right now. And if you come from a clinical officer training and you don't know what implants are and how they should be inserted, then that's a missed opportunity. We must much more look at the skills that people should have, because all those young people, we are going to place them in a remote area, and even if we are going to give them some mentoring, they should have more skills than they have now. So we need to look at the future. What is coming? All those people are going to work with apps and ICT. How much do they learn in schools about ICT? So we must focus our training on getting people who can function for 40 coming years in a health system that is changing rapidly. And also for continuing professional development, we look at ways to really make sure that people get to know and can implement the work that they're doing. So human resources for health, if you ask me, this is the major priority to take a leapfrog forwards to make it ready for the new era. And I hope that the coming high-level human resource meeting that you will have on 15th of November will address these issues. ICT is very important, but as we said, we are looking at primary healthcare 2.0. It should really be strengthening primary healthcare. All these apps, you can use them in a smart way. I was explaining yesterday, we have a project in Bangladesh where the nurse starts a partogram on a tablet, and the gynecologist 100 kilometers away can follow the partogram while it is being written on the tablet. And also in Tanzania, they have done a similar experiment in one of the hospitals. That kind of technology helps us to really make sure that the basic things that we want people to use, partograms, are being taken to a new era with a new type of supervision. So all these telehealth, all these apps that can be used should really work together to create a new type of primary health care. And we should not leave ICT to the technology people. If we get all those nerds determining what we should do with ICT, it is going to be a disaster, and it's going to be a new overload. So we must use and put people with knowledge about the healthcare system in the lead of developing ICT in a way that it really will bring a new type of health services together. Of course, there's a lot of ongoing business, and we want that to be strengthened. Quality has been mentioned as one of the major issues. There's a good forward development, but we see also some areas where quality can improve with more coordination, bringing those formularies and electronic patient records together, and make sure when I type in the Netherlands a diagnosis in a computer, then I get a pop-up of differential diagnosis. I get a pop-up of possible medicines that I can prescribe. So if you use technology, you can use that much better in quality. So those kind of issues are important to look at quality in an integrated way. There's a tremendous progress in commodities and supplies, we know that, but as has been mentioned yesterday by Wema, if we want really to have the full package covered, we need to have a next step in medical supplies, not only the most essential, but also the full package for the interventions at the facility level. Performance management systems are good, but then you should really make sure that they work. So if you have an OPRAS or another type of performance assessment system, people should advance in their career. If it is a paper exercise, then it doesn't help. If you have RBF or HBF, it should really be linked to the performance, the incentives that people get. So that is important to have many of the activities that are going on and developing well, continued also under HSSP 5. We are not starting from scratch. HSSP 4 was there. There's a lot of business that we want to continue, so we want you to think about that as well. But the new challenges, the NCDs have been mentioned time and again. We need a radical change in approach to really make communities work on NCDs. Look at the social determinants. But as has been mentioned also, we have to look across the age cohorts. we are very happy that life expectancy is raising, but that brings a new type of thinking on how to help those people in older age with their maybe limitations or their possibilities. So looking across the lifespan is important in our next strategic plan. Urbanization, I mentioned already, new threats, new epidemics. We see dengue now in Tanzania. I never saw dengue when I was practicing clinic here in Tanzania. So Zika, all those different types of diseases that come up, we need to look at that. I mentioned yesterday the One Health approach, many of those diseases, and we need to make sure that we work together across the sectors to address those kind of diseases. Community health was mentioned, and yesterday it was mentioned that the community health strategy is already under review, so I hope that some good things come out of that. But again, here are many opportunities that we should use in a comprehensive way. And of course, gender is not only an issue for communities, but is across the board as a cross-cutting issue. So those are some of the recommendations that I want to give to you from the midterm review for your discussion this afternoon. And you will all receive some paper with the instructions, and there the recommendations are also mentioned. So there's some way of thinking about it. We divide you in groups, in 7 groups, and each group is going to discuss 3 questions. 1, what is the big picture? And we put you together from different backgrounds so that we have a really cross-cutting discussion. What are the views that you have are important for the coming 5 years? That's the first hour of discussion that you're going to have. The second one is within the thematic area that you are going to be assigned to. What are the strategic directions? What are within the theme the big strategies that we should develop in the coming 5 years? Or the strategies that we should continue from HSSP 4. Okay, so what is within the theme the most important that we want to achieve? That's the second hour. The third hour is on the policy priorities or strategic priorities, as I would prefer to name them. What out of these strategies that you have developed as an idea for the next phase, next HSP 5, what are the ones that we should address in the next year? So because the next year is already part of HSSP 5, we want you to look at it. But at a strategic level. So don't say we need to buy 500 cars for every health facility. That kind of operational planning is not what we understand as strategic priority, annual priority. So for the big picture, where do we want to be? And you look at the context, the changes in society, what we all mentioned, the building blocks, service delivery, very much along the lines that Dr. Mapunda showed you on the slides that are important in the strategic development. So this is brainstorming. So no idea should be refused because PSM says that you can only have civil servants working in a government facility or other restrictions. Think broadly, we come to the reality check later. But of course, it should not be too crazy if you want helicopters in every health facility. It's not going to work. So think broadly, but within reasonable terms. But also think out of the box. The second step, you start with looking at the recommendations that came out of the midterm review, but you add, you modify, you amend. You are not restricted to say, okay, those guys of the midterm review are prescribing what we should do, so we should follow that. No, use your own initiative. And I heard a lot of things this morning that I said, oh yes, those are good ideas for HSSP 5. So make use of your own background, your own experience, your own knowledge to enrich those strategic directions for your themes. And finally, translate a few of them into the priorities for next year. So we will have 7 groups on governance, health financing, human resources for health, M&E, ICT, service delivery, ongoing business, and we include here commodities and supplies because we think that should be very much linked. It is not to be used in isolation. The new challenges, and finally community health. So we will divide you in groups and you will look at it. So the process is you select, we have selected a chair already, Dr. Catherine. So there will be a chair appointed by the Secretariat. You will select a rapporteur. One of the MTR consultants will be in your group to moderate, to help keeping the discussion on track, but also helping the rapporteur to put together the report. Because tomorrow we are going to have the feedback from your groups, and we are going to hear your ideas that come for the formulation of HSSP 5. So your inputs now are the start of HSSP 5. And as Dr. Catherine explained, we will work on that, or the new team will work on that to make sure that we have a rough outline of HSSP 5 by December. So this is your moment. Take your chance to make a major input and give a direction to HSSP 5, because all the good ideas that are floating around, we should capture them and bring them together and make sure that HSSP 5 is going to be a vibrant plan that is really going to help us all. And of course, it should be owned by everybody. And that's why we need the DMOs and RMOs to be here working with us, but also disseminating ideas and picking up more ideas along the road while we are formulating HSSP 5. So once more, this is the topics that we want you to look at. How can they be incorporated in HSSP 5? There was the presentation from about the health and all policies from the WHO about the strategic plans for improving health. Think of those as well when you look at the ideas for formulation of HSSP 5. Madam Chair, with this I would like to give the word back to the moderator. Maybe there are some questions for clarification. During lunchtime, we are going to reorganize the room so that we can have the 7 groups. You're going to read on the wall there near the door in which group you are. Please stick to that. We don't want 200 people in RMNCH and 1 person on human resources for health. So we really divided you to make sure that we get different inputs. And then hopefully by tomorrow we have very good presentations from you that can help us to start the work on HSSP 5. Thank you very much.
Thank you very much, Yap. Thank you very much. And I'm not sure if there are any questions. So what I'm going to do is to announce the group leaders of the groups. Reading all of you for the group, it will be too much, but you'll see over there. So group one will deal with governance, focusing on D by D, swap coordination, health in all policies, etc. And that will be led by Dr. Grace Magembe, and the facilitator will be Professor Gaspar Munishi. And a rapporteur will be selected among the group, maybe from the secretariat, who will be presenting. So, and that group is people from various levels, including RMOs and whatever. Group 2, this is healthcare finance. It will talk about innovative approaches, single national health insurance, resource mobilization, and around that. And it will be led by a young man, Alex Rutabukubana. Can you stand up? They see you, Alex. Alex, yeah, there, on the corner. And our only Sally Lake will be there as a facilitator. Sally, are you there? Yes. Good. Then we have group 3, human resource for health, HRH planning, management, development, both pre and in service. Dr. Saitore Liza, he was sitting there with the chair. Where is he? Yeah, he was chairing this morning. He will chair this group. He has a battery of advisors, consultants. Hadija Kweka, our sister there. Rutasha Dadi, over there. And our own Catherine also will join that. Yeah, okay. MNE and ICT. This is a duo, you know, we Muslims have marriage of 2 wives. So this is one of them, MNE and ICT, where they'll focus on PHC 2.0, data generation and data use, data system. So we will have 2 leaders, Eric Kitali and Tumainieli Macha. Eric Kitali from Porak and Tumainieli Macha from Ministry of Health. And they'll be supported by 2, Professor Simba and Henry Mole. Then group 5, service delivery 1. That's the day-to-day, quality system, commodity supplies, RMNCH, referral system. We'll have Dr. Eliudi. Big Bang, where are you? Eliudi Eliakim, yeah, over there. And our Dr. Makwani. Ahmad, where are you? Ahmad Makwani. Oh, okay, thank you. You are heading there. So this will lead the group. And they'll be supported by my director, Berege. You'll be there. Wema Kamzora, where are you? Yes, Wema, yes. Professor Siam Suya and Angelo Nyamtema. Community systems, I'm sure. Community systems, community business programs, paradigm shift, community health workers, gender, health, Saturin Manangwa. Is that correct? Saturin Manangwa, can you, yeah, over there, with Daud Nasibu and Professor Rachel Manongi. Yes, thank you. That was group 7. Yeah, great. Now, our esteemed former leaders, should I follow the order of seniority or the order in the list? Group, yeah. Dr. Kimambo, governance, group 1. Saba. Dr. Hingora, healthcare finance. Governance. Dr. Upunda, you talked about the fellowship training, human resource for health. Dr. Rashid, we have so many systems around, M&E and ICT. Dr. Lipioga, Service Delivery 1. Dr. Lipioga so is here, Service Delivery 1. Dr. Mbuji, Service Delivery 2. Maybe that's one I didn't read, eh? Yeah, Service Delivery 2. And Dr. Mbando, Community Systems. Did you say something about community? Yeah. So let me look for the Service Delivery 2, which I didn't read. It's here. Group 6. Group 6 is Service Delivery 2, Upcoming Epidemics, Environment and Climate Change, NCD, Emergency Preparedness. Dr. Charles Kiologwe will lead this. Can you raise your hand or stand up? Yeah, okay. Service Delivery 2 is the new challenges. New challenges. Yeah, NCD is the line. Okay. That's number 2. Say group 6. Yeah. Let me finish this first and come back. Charles Kiologwe will lead that, and El Huruma Nangawe will be the facilitator. Okay? So the names will be posted, and let me come and okay, so I was clarifying something, but we are okay. So we go for lunch and then we go to the groups, correct? The room will be arranged for the groups while we are having lunch. And lunch will be 1 hour. After that, you come back, and then we'll see how we go. Okay? So 3, we start the group discussions. Yeah. So 1 hour at 3. At 3 we assemble here and start. You'll find your groups, but you'll see your groups over there.